Welcome back to the channel. Today we'll take a deep dive into the comprehensive workup for cardiac amyloidosis, a condition that is often underdiagnosed but has significant clinical implications. We'll cover key clinical clues, laboratory findings, imaging modalities, and biopsy techniques to help you confidently evaluate and diagnose this disease. Let's get started. Step 1. Clinical evaluation. A thorough clinical assessment is critical in suspecting cardiac amyloidosis, particularly in patients presenting with unexplained heart failure with preserved ejection fraction. Key history red flags include recurrent hospitalizations for heart failure despite guideline-directed therapy, autonomic dysfunction manifesting as orthostatic hypotension, peripheral neuropathy, carpal tunnel syndrome, or macroglossia, which are particularly suggestive of AL amyloidosis. A family history of amyloidosis should raise suspicion for hereditary ATR amyloidosis. On physical exam, look for jugular venous distension, peripheral edema, and hepatomegaly. Low blood pressure despite a normal or high stroke volume, indicating restrictive cardiomyopathy. Bruits or diminished pulses, suggestive of vascular involvement. Step 2. Laboratory tests. Once clinical suspicion is raised, targeted serologic testing is the next step. Serum and urine protein electrophoresis with immunofixation to assess for monoclonal protein production, AL amyloidosis, serum free light chain FLC assay to evaluate for abnormal key kappa or leta lambda light chains. NT-proBNP, often disproportionately elevated relative to the degree of left ventricular dysfunction. Troponin T or I, which may be elevated due to direct myocardial injury from amyloid infiltration. Genetic testing for transthyretin TTR mutations, which is essential to differentiate wild-type ATR from hereditary ATR amyloidosis. Key point here is that normal cardiac biomarkers do not rule out amyloidosis, especially in early disease. Step 3. Serum free light chain FLC ratio. For AL amyloidosis, the FLC ratio is a critical diagnostic tool. Normal ratio, 0.26 to 1.65. If the ratio is extremely abnormal, the likelihood of AL amyloidosis is very high. Additionally, an absolute free light chain level 50 mg per milliliter further supports the diagnosis. Step 4. Imaging studies. Non-invasive imaging is fundamental in the diagnosis of cardiac amyloidosis. The imaging modalities of choice include echocardiography, cardiac MRI, and nuclear scintigraphy. Echocardiography, TTE with strain imaging. Left ventricular LV wall thickening 12 mm without another cause. Biatrial enlargement. Restrictive diastolic filling pattern. Apical sparing on global longitudinal strain, GLS. A key differentiating feature from hypertrophic cardiomyopathy. Cardiac MRI, CMR, with late gadolinium enhancement, LGE. Diffuse subendocardial or transmural LGE in a non-coronary distribution. T1 mapping and extracellular volume ECV expansion, quantifying amyloid burden. 99 ETC pyrophosphate scintigraphy, PYP scan, a grade 2 or 3 uptake with absence of monoclonal proteins, strongly supports ATR amyloidosis. This test has 99% specificity for ATR amyloidosis when properly interpreted. Step 5. Biopsy, the gold standard. While non-invasive imaging is highly sensitive, a biopsy is required for definitive diagnosis, particularly when differentiating between AL and ATR amyloidosis. Endomyocardial biopsy, EMB, is the gold standard when cardiac involvement is uncertain. Congo red staining shows apple-green birefringence under polarized light. Mass spectrometry identifies the amyloid fibril type. Fat pad, kidney, or bone marrow biopsy may be an alternative but has lower sensitivity for cardiac involvement. Step 6. Additional tests. Other investigations include electrocardiography, ECG, classically shows low voltage despite LV thickening and a pseudo-infarct pattern. Holter monitoring for arrhythmias or conduction disease. Genetic counseling, which is essential in hereditary ATR cases. Final diagnosis summary. To consolidate our approach, AL amyloidosis is diagnosed by monoclonal protein detection on SPEP, UPEP, or FLC assays, often with multi-organ involvement. ATR amyloidosis is diagnosed with a positive 99 MEDTES PYP scan and the absence of monoclonal protein, with genetic testing confirming hereditary forms. Early recognition of cardiac amyloidosis is critical, Prompt diagnosis can significantly impact prognosis, particularly with emerging treatment options for both AL and ATTR amyloidosis. If you found this breakdown useful, be sure to like, subscribe, and share for more high-yield cardiology content. See you in the next video.